Fellas, you know Degree Cool Rush deodorant, right? Well, last year they changed the formula, and guys were mad about it. One dude even started a petition. So guess what? Degree heard us, admitted they messed up, and brought the original Cool Rush scent back exactly how it was. And it's in Walmart, Target, and other stores now for under $4. So grab some and remember why its cool, crisp, and fresh scent made it the #1 men's antiperspirant for the last decade. Degree Cool Rush is back, and it smells like victory for all of us.
The last thing you want to hear when you need your auto insurance most is a robot with countless irrelevant menu options. Which is why with USAA Auto Insurance, you'll get great service that is easy and reliable, all at the touch of a button. Get a quote today. Restrictions apply. USAA.
This week, we are sharing essential information that every parent should know to make sure that they can help to keep their baby or young child safe. I'm joined by Paediatric ED Doctor, Dr. Lillie Parker.
There's quite a lot of things that you can look out for, and as I said, that's partly because you can see things in a baby that you maybe can't see in an adult. You know, the function of breathing is to get oxygen in and out of the body.
Bronchiolitis, so that's something that we are hearing about all the time at the moment. What do you want parents to know about that?
The most common things we see when it comes to breathing things are probably...
Hello, I'm Pip, and welcome to the Midwife Pip podcast, the home of expert information and real chats on all things pregnancy, birth, and beyond. This week, we are sharing essential information that every parent should know to make sure that they can help to keep their baby or young child safe. This week, I'm joined by Paediatric ED Doctor, Dr. Lillie Parker, to make sure you have the very best, reliable and expert knowledge on this important topic. So welcome, Lillie, and thank you so much for joining me because you have just come off your night shift, so you're a total hero.
Thanks for having me again, Pip. It's always nice to chat.
I am so excited that we get to cover this topic because we were just talking a little bit before we hit record on how massively common respiratory stuff, illnesses, concern is amongst parents at the moment. So talk to us, if you can, Lillie, a little bit about what normal breathing should look and sound like.
Sure. I think, as you said, it's a bread and butter of children's A&E. You know, we see this day in, day out. All ages, from newborn babies all the way up to older children. And I think fundamentally the first step to knowing when to worry about your children with their breathing is knowing what's normal. And I think that can be quite difficult sometimes, actually. And the younger a baby is, the more challenging it is to know what's normal, because often, especially with newborns, they haven't quite settled into their total normal yet. And one thing I always recommend is that you, as a parent, take a video of your child when you do think they're breathing completely normally. Sometimes if they're asleep, it's really helpful to have an idea of what their normal breathing looks like when they're completely well, so that then you can compare it a little bit if you're worried, or if you're thinking they're looking unwell, to a time when you knew that their breathing was normal for them.
That's such a good idea, isn't it? Because like you say, to start with, like, we don't really know them yet. So we're trying to figure out. And babies can be really noisy, like within a range of normal, they can be noisy. So you might be expecting them to be completely quiet, and they're not always.
No, I think newborns are often the hardest because, as you say, they can be quite noisy. They do a lot of coughing and sneezing, which can be normal, but it also can not be normal. They breathe very fast. And I think a lot of people who are not medical or are not medically trained are not expecting them to breathe quite as fast as they do. So we know that normal newborns breathe around 3 times as fast as an adult. So a normal breathing rate would be anywhere between kind of 40 and 60 breaths per minute in a newborn, which actually to an adult looks really fast.
Yeah, and if that was us, we'd be really concerned.
Yeah, breathing 1 per second is really quick, but actually that is normal for a newborn baby. And as babies grow up and toddlers and children get older, their breathing rate gradually, the normal settles down to adult rates, which is around 15 to 20 per minute. But it doesn't actually get there until you're around 12. So it is normal for children to breathe faster than adults. So I think that's the first thing, is having an idea of how fast your child normally breathes. And with babies, I usually say up to 1 per second is fine. But if it's more than 1 per second, then that's a bit quick. With older children, it's kind of maybe 1 every 2 seconds or 1 to 2 seconds. But again, if they're breathing more than 1 per second, that's quite fast. And as I said, it's helpful to know what your child's breathing looks like normally. And sometimes in a panic, when you're worrying, it is helpful to have a video of that so that you can compare. I think the other thing to note is that newborns and small babies, their chest walls, so their rib cages, are quite soft. So they're not bone like adults. They're made up mostly of cartilage, which is the slightly softer material than bone. And as children get older, their ribs become fully formed into bone. So when you're a little baby, your chest wall is just a bit more compliant than an adult, so it will move a bit more, and you will be able to see more of their muscles working to make them breathe, which partly is normal, but also means that when children are struggling to breathe, their chest wall moves a lot more than an adult would. So it can give you some really helpful signs to look out for in terms of when they're struggling to breathe, because you will see it, but equally, even when they're well, their chest wall will move a bit more than an adult's would when you're looking at it. So it's knowing that actually they don't have bony ribs the same way that an adult does, and you will see them breathing a little bit more than you would expect possibly in an adult.
That's really helpful, because I think unless, with all things often in the medical world, unless we understand the normal physiology, it's impossible to then determine when there's a deviation from that or when there's something to be worried about. So to kind of flip that on its head, Lillie, what does difficult breathing look like or sound like? And are there any things that if a parent did see in their baby, you'd want them to kind of register as red flags straight away?
Yeah, there's quite a lot of things that you can look out for. And as I said, that's partly because you can see things in a baby that you maybe can't see in an adult. And actually, the function of breathing is to get oxygen in and out of the body. That is the reason that we breathe. Oxygen is really important for all of our organs and our brain, and it is a priority. Our brain prioritizes getting oxygen in and out. So if there is something happening in their lungs or their upper airways that is meaning that it's more difficult for you to get oxygen in and out, your brain is going to basically instruct your body to try harder. So it will say to your muscles of your chest wall, to the muscles around your throat, you need to work harder to try and get more oxygen in, because currently we're not doing a great job of this. And the way that you will see that is, well, it does depend on your child's age. Obviously, we're covering newborn to like 10-year-olds, but I would say in small babies there's more signs. But you will see those muscles of the chest wall and the muscles around the kind of airways working harder, and you'll see them pulling in or out to try and get the rib cage and the airways to open to allow the oxygen to go in. And we call those recessions, or if you're American, you call them retractions. But in essence, you might start to see the spaces between your child's ribs dip in. You might start to see the bottom of their rib cage dip in more. You might see their sternum, which is the bone right in the middle of your chest, going in, and your trachea, which is your airway up in your throat. So that might start dipping in as well. And that's because you're seeing all the muscles literally dragging the space open to allow more oxygen in. Equally, small babies might flare their nostrils a bit wider. Again, that's to try and get more air through the nose. And you might start to hear some extra noises. And some of those are because of the work of breathing, because it's hard to breathe. And some of them are because of what's happening inside in the airways being narrowed. And there is a wide range of different noises you might hear, all the way from a simple blocked nose, which makes your baby sound snuffly or snorty because they just cannot breathe through their nose, to musical noises such as what we call stridor or wheeze, which are where the airways inside have become narrowed, and you're starting to hear the air going through those airways. A bit like if you blow over the top of a bottle where it's narrowed, you're hearing that musical noise from where the airway is small and the air is going in and out through it. So I think those are the main things to look out for, are the sucking in of the ribs, the sucking in of the chest wall, which we call recessions, tracheal tug, which is the sucking in of the soft airways, nasal flaring, and then noises, be that wheeze, stridor, snuffliness, snortiness, and then another noise which we call grunting, which again doesn't always sound like grunting, but in essence, when a baby's struggling to breathe, they make a noise when they're trying to breathe out, and it will often sound a bit like
and often parents will describe grunting as like a cute baby sound.
Yes.
And then you're like, no, it's not a cute baby sound. But it can just sound like almost especially if they're asleep or they're very calm, it almost sounds like a soothing noise, doesn't it? Because it's quite rhythmic.
Yes. So it can be really mild or it can be more severe, and it can just sound like sighing a little bit again and again and again. But it's something that happens on every breath out for a sustained period of time. So if your child just does it once or twice and then it settles, it's probably just keep an eye out, see what happens. But if they're doing it on every breath for more than kind of a few minutes, then I would start to be worried that they're actually doing it because they're struggling to breathe, rather than, as you say, a cute baby noise or, just a little bit of a noise that they're making. But grunting is very variable and different babies will sound different. And I'm not sure that the word grunting is that great because it doesn't really sound like grunting to me anyway. I mean,
yeah, I know what you mean, because I think when we think of grunting, we think of like, I don't know, like a harsh teenager that's kind of like, huh, and like it's quite aggressive, doesn't it?
Yeah,
deep,
or like
and actually it doesn't sound like that.
Wild boar or something, I don't know, making really loud noises. Yeah. It's often a lot softer and a lot more delicate and high pitched than you expect.
Yeah, I'm not sure I can think of a better word to describe it mine, but I know what you mean. It doesn't quite mirror it. But like airway is so important, isn't it? Like it is so essential to sustain life, which is why parents naturally are so worried when they've got a tiny newborn that's it may just be a cold, but it sounds so much worse, doesn't it, in such a small body?
It does. And so newborn babies, they only breathe through their nose. They haven't yet established the pattern of being able to breathe through our mouths. Now, all of us naturally will breathe through our noses because our mouths have other functions like talking or eating. And therefore, it wouldn't be good if, that's why we have a nose, so that we can breathe through it and do other things. But babies haven't quite grasped that yet. So if they can't breathe through their nose, they're not good at compensating by breathing through their mouths. They will often just pause their breathing or stop breathing altogether because they don't know how to do it yet. And therefore, in a small baby, and this is generally under kind of 6 months of age, so around 6 months of age, they start to be able to breathe better through their mouth. But kind of before that 4 to 6 month period, then if they get a cold or even a slight bit of swelling from a viral illness in their nose and they can't breathe through their nose, they may have some quite significant signs that they're struggling to breathe, even though the underlying illness is not one that is particularly severe, because they don't know how to compensate. And the way that you will see that is you may hear them being noisy, like we said, and they're getting some air in and out. But if their nose is completely blocked and they're not able to get air in and out that way, they won't be able to feed because they won't be able to coordinate sucking and breathing at the same time. So they will start to refuse bottles or breastfeeding, and you might try feeding them and they'll only take it for a few seconds and then kind of spit it out and start choking or spitting out things because they can't get the air in. And they might do that thing where they start pausing their breathing, and that can be really alarming for something that might actually be quite a mild illness, but it may still need help from a doctor or help in hospital because they haven't yet developed the mechanisms to get around it.
Yeah, it makes sense. And I guess something that I know we've spoken about before, Lily, and you often speak about, is that parental instinct. So actually, if you don't ever feel worried that you're necessarily wasting someone's time with just a cold, especially if you have got a tiny baby and you just can't tell, they can't tell you, you don't know them yet. Always better when it comes to anything airway, just to have that check over, right?
My brand new book, Midwife Pip's Guide to a Positive Birth, is now available. So much more than a book, this is a guide that allows me to hold your hand through your birth preparation journey. With over a decade of experience and knowledge packed in, to ensure you really are empowered in the way you deserve to achieve a positive birth, regardless of the twists and turns that crop up. Make sure that you get your hands on Midwife Pip's Guide to a Positive Birth book now and are empowered to have the birth experience that you deserve.
Yeah, and as you said, airway is possibly the most important. Well, it is the most important thing to sustain life. So, as doctors, we work through an algorithm when we assess a patient, and it is A, B, C, which is airway, breathing, circulation, and that's because airway comes first. Airway is the most important thing, and if you don't have an airway, if you're not able to get that oxygen in and out, you only have a few minutes before you wouldn't survive it. And therefore, that is why I think it's so important that parents do know when to worry and when not to worry so much. But I think it does inevitably induce anxiety if you don't feel confident in what you're looking at. And I don't think you would ever be criticised for coming to see a doctor or a healthcare professional because you were concerned about your baby's airway or their breathing. I think it's important to have some knowledge, but if you don't feel sure, ask for help. There's so much help out there, and there's so many people that would take your concerns seriously if that is what you're worried about.
Definitely. And I think often, people think, oh, well, if I am just sent home, like I feel a bit silly. But actually, as a medic, there's probably nothing that brings you as much joy as when you can see someone and just reassure them and send them out the door. Like, that's fine.
Yeah, obviously, like you're here, I'm here on social media. We're all trying to empower parents with the knowledge so that they don't need to come to hospital when they don't need to, because we all know that the NHS is busy and that you'll end up waiting a little while. But having said that, we would still rather see you if you're really concerned, even if we then see you and think, actually, this is fine. We can give you a bit of education, then we can talk you through what is normal, what is not normal, and what we're seeing. And I think, as you said, it's better to get them checked out if you're worried. But if you're listening to this podcast, then that's a really good first step because you're going to know a bit more than the average person.
Yeah, and I think just take time. At the moment, we've got some lovely weather. So actually take time to watch your baby's normal breathing, because often just in the day-to-day, especially like when it has been winter and they're perhaps layered up, you may not have spent that much time actually observing their body and observing them breathing. So actually, if you can just take a little bit of time to watch what's normal for your baby and just tune into it a little bit. Because I think it can go a little bit missed just because you're busy and you're doing the nappy change and maybe singing to them, but just taking that little extra moment to check in so that you've got that confidence in their norm.
Yeah, for sure.
So what are the common things that you see? Because you obviously see so many little people coming through your department, coming into your hands with respiratory conditions. What are some of the kind of common things that are cropping up, and how can parents try and recognise them?
Sure. As you said, I think we see a lot of different things. The most common things we see when it comes to breathing things are probably croup, bronchiolitis, lower respiratory tract infections, which some people might call chest infections, upper respiratory tract infections, which is like your common cold, and something we call viral induced wheeze. And the majority of those things are all triggered by viral infections. There are bacterial chest infections that can happen, but compared to viral infections, they are a really small proportion of what we end up seeing in hospital. And the majority of breathing stuff we see is caused by viruses. The difficulty of that is that we don't have magic cures for viruses in the way that antibiotics, kill off bacteria. And so the majority of what we do in hospital is supporting children through these illnesses so that their own bodies can fight off the underlying virus, but we may need to help them with medications to treat some of the symptoms that they're having. And I think all of these illnesses, to some extent, cause some degree of either swelling of the airways or excess mucus production. So your airways are little tubes. They lead to these little things called alveoli, which are where the oxygen goes from the outside world into your body. And there are thousands, if not hundreds of thousands, I mean, I'm not a very good physiologist, but of these in your lungs. And they're really small. And in your babies, they're even smaller than in an adult, obviously. And therefore, when you get a virus and it goes into your airways and starts to cause swelling and excess mucus production or snot, basically, in your airways, those little airways get blocked off or narrowed. And it can be you get both of those things. So some of them get blocked off, some of them get narrowed, or in some of these illnesses, you just get the narrowing. But either way, the air that we talked about earlier, the oxygen, doesn't get in quite so well. And that's when the brain starts indicating that you're struggling and that you need to work harder with your breathing. So you'll start to see the signs that we've talked about in your child. And different illnesses cause a different pattern of signs. So, for instance, in croup, which typically is caused by one virus, but we actually know that quite a lot of viruses will mimic the same symptoms. So croup causes airway swelling in the upper airways, so the bit of the airway above the lungs and around the vocal cords. And that area becomes swollen and narrowed, and you start to hear noisy breathing. So something we call stridor, which is a noise on the in breath. So it'll often sound a bit, I'm not very good at mimicking this, but
That's a great stridor sound.
Okay, good. That's stridor. And when they cough, because they will start to cough to try and clear their airways, they start to have this barking or seal-like cough that people describe. And that's typically when parents are like, oh, this cough sounds weird. I've maybe heard of croup, or someone we know's had croup, and they will often identify croup when they hear that barking cough. But sometimes they won't identify the stridor noise quite so well as croup. So I think it's really important to know that you can have both, or you can have one or the other. But that's being caused by upper airway swelling. And really all we have in our locker for that in the hospital is that we can give a dose of steroid medication, which reduces the swelling and opens up those airways. So it is really helpful. And my experience is that the majority of children, even if they're really struggling to breathe, once we've given that steroid and we've given them some time, will improve. Sometimes they may need other interventions like some nebulized medication, but we can do quite a lot of things to reduce the swelling in the airways, which will make it easier for them to breathe. And then if you move down into the lower airways, so those smaller airways, when they become narrowed due to viruses, you get what we call a wheezing noise. So that is a musical noise on the out breath, and it's because of swelling, as I say, not in the upper part of the airways, but in the actual lungs themselves. And we know that there are tens of viruses that can cause swelling in the lower airways. And the smaller the child, the more likely it is to cause an issue. But we see a huge amount of what we call viral-induced wheeze in the kind of 1 to 5 age bracket. And I think one thing that parents often find very confusing about this is it presents very similarly to asthma, but actually it's a very different mechanism. So we know that children who don't have asthma can still get recurrent viral-induced wheeze when they get a viral infection. Asthma is the same thing, so it's narrowing and constriction of those airways, but typically not just induced by infections, also induced by other things like exercise, cold air, allergies. And therefore, if your child is completely well when they're well and they never get any symptoms, and then when they get a cold, they get wheezy, that doesn't mean that they have asthma. It means they probably have viral-induced wheeze. And the majority of children will grow out of that, but they may end up coming into hospital even relatively frequently, getting these virally wheezy episodes. And again, we treat those with steroids, but also we have lots of nebulized medications and inhaled medications we can give you to open the airways up, to make things easier. And really it's identifying that they sound wheezy and that they've got those signs of increased worker breathing to bring them in. And a lot of these viral respiratory illnesses have crossover. So you might end up having lots of these signs, and it can be quite difficult as a parent to say, no, we don't expect you to be a doctor. I think that's my point here. We don't expect you to say, my child has croup, or my child has viral-induced wheeze, or I know that they have pneumonia. What we expect you to be able to do is to pick up on the signs that they're struggling with their breathing, and maybe that their breathing isn't normal for them, and knowing when they need to come in. And we can then make that decision about what viral illness it is that they have, or if there is any bacterial element, if they need any antibiotics. But I think my point is that majority of these will not need any antibiotics, but they may need other medication or treatment to help. And for a lot of children, they may need nothing. They may just need observation and don't feel that was, like you said before, a wasted trip to get them checked out if you think that they have breathing problems, because these illnesses fluctuate and sometimes they might look okay when you come into hospital and look worse at other times, and they may end up needing several reviews in one illness, and that's okay too.
Yeah, it's such a good point, because children are very different, I think, to us as adults. They're very brave. They're quite good at pretending they're okay, aren't they? And they really do go up and down quite quickly. Like, I remember with ours when they've been poorly, 1 minute they're like led on the sofa, can't move. And the next thing they're running around like, crazy things. They really do sort of spring up and down, little people, don't they? We're just hitting pause for a moment whilst I share something new and exciting with you. Have you ever wondered what's normal and what's not when it comes to your baby's poo? The colour, texture, and frequency of your baby's poo can provide valuable insight into their health and development. It can also help you determine when to seek advice from a healthcare professional. AptaClub's new AI poo tool makes it easy to understand what your baby's poo might indicate. You can even upload a photo, and the tool will analyse it to provide helpful information. You can check it out now at aptaclub.co.uk/baby/baby tools/poo tracker.
They do. Children want to play, and we actually have a phrase in the hospital which is the happy wheezer, which is children who have a viral lower respiratory tract infection, this viral induced wheeze that we talk, and often they won't always have a high fever, they won't always look really poorly, they will just have some of this swelling in their airways that's making it difficult for them to breathe. So they might be quite happy with themselves and willing to play or interact with you, but they are working hard with their breathing and they are making this wheezing noise, and therefore they do need some treatment to help them with that. But often as soon as you give them the treatment and open up their airways and they feel like, oh, I can breathe again, they'll be running off around the playroom and trying to play and act, and run around. And it's really difficult, because if it was an adult, you would say to them, you've got some breathing problems, you should probably take it easy, rest a little bit. We've given you some medication, just take it easy and quiet. But a 2-3-year-old, they don't understand that. And basically, as soon as they feel a bit better, they're off. And so we just work around that in hospital. But the reality is that a lot of the children we see are still happy and playing, but they still do need some hospital treatment or management.
Children are so amazing, aren't they? They're just so brilliant. And I love how they're always brutally honest as well.
And there's no real fake, children don't really fake it. I think, or feel sorry for themselves in the same way that adults do. When we're really sick, we often feel a bit sorry for ourselves and think, oh, I'm going to take it easy. And even when you start to feel better, you think, no. But children don't moan or whine. As soon as they feel better, they're up and they're off and they're playing. Yeah. And it's so easy as a paediatrician to know when you've made them feel better because of that.
Yes. And so rewarding for you as well, I imagine, to see them back to their fulfilled self.
It is.
And one of the other things, Lillie, was bronchiolitis. So that's something that we are hearing about all the time at the moment. What do you want parents to know about that?
Yes, bronchiolitis, huge topic. We could probably do an entire podcast around bronchiolitis in itself. So bronchiolitis is another one of these viruses that causes respiratory problems and typically affects babies. And most children will have bronchiolitis at some point before the age of 2. You may or may not know that your child has had bronchiolitis, because they may get it really badly and end up needing some hospital treatment or some treatment by the GP, or they may just have a bit of a cold and a cough and you don't really know that they've actually had it. But almost all of us will have it at some point. And adults can actually catch bronchiolitis as well, because it's just a viral illness. But for adults, it will probably be more like a bit of a cold and a cough. And typically it's caused by one virus, which is called respiratory syncytial virus, or RSV. And that peaks in the winter months. So it starts to rise around September, October, peaks around December, January, February, and then starts tailing off. There has been a little bit of a disruption in that over COVID, but we are seeing that pattern start to come back again, where it definitely is peaking in the winter and better in the summer. It's not impossible to catch it in the summer months though. But we also know that the signs and symptoms of bronchiolitis can be mimicked by some other viruses. So sometimes we will test children to see if they have RSV when they come in with symptoms of respiratory distress, and it may be negative, but we will still label what we are seeing as bronchiolitis, even though they don't have RSV, they may have another virus. And that's because we know that the symptoms really and the signs of bronchiolitis are that you get this narrowing of the airways, but also loads and loads of mucus production. So they get really clogged up airways full of snot, which they struggle to shift. So they will be coughing a huge amount, they will be struggling to breathe a little bit or a lot. And when you listen to their chest with a stethoscope, you hear a combination of wheeze and crackles. So you know that both things are happening at the same time. They have narrowing and they have loads of mucus. And for some older children, this won't be a huge problem. They will be able to fight it off on their own. But for younger babies whose airways are small and don't take much clogging or narrowing to cause big problems, bronchiolitis can be quite severe. And really, as a parent, the things to look out for are the things that we've already talked about. But we know that in babies, especially young babies, it will start to affect their feeding, and it will start to affect their oxygen levels. Now, you don't know what their oxygen levels are at home, and we don't expect you to. And I never really advocate for parents to buy these home oxygen monitors because they're not very reliable and they can induce a lot more anxiety. You will know if your baby's oxygen levels might be low by the way that they're breathing. Because as I said, once it starts dropping your oxygen levels, the brain tells the body to work harder with the breathing, and you see the signs. So if your baby looks like they're completely settled, the chances of their oxygen levels being low is very, very slim. So I think the things to look out for are if they're struggling to feed, like we talked about before, so they're not going on to the breast or the bottle, or they're just taking a little bit and then coming off, they're coughing and spluttering a lot. If at any point they start taking less than 50% of their normal feed, or if they have these signs of respiratory distress, then you should get them checked out by a health professional. And as I've said before, that the babies who struggle with this the most are often the younger babies. So they're kind of under 6 months. Those are the ones that end up in hospital. And if your baby ends up in hospital with bronchiolitis, really the things that we are doing are just supporting them to fight the RSV virus. And the way that we do that is by giving them oxygen or respiratory support if they need that. So we can blow air and oxygen up their nose. We can blow just oxygen up their nose. If we really have to, we can take over their breathing entirely for them. And then we can support their feeds, either by giving them little and often feeds, or by putting a little tube down through their nose into their tummy, so they don't have to worry about feeding, and giving them food that way so that they can have a complete rest but still stay hydrated. So those are the kind of things we might do in hospital. And the tricky thing for us really as doctors is that a lot of the medication that we give older children, like the steroid medication, the inhalers for wheeziness and stuff, the evidence just is that it doesn't really work in younger babies for bronchiolitis. So I find this really frustrating because it's something I see all the time, is that I don't feel like there's a huge amount that I can be doing to make babies with bronchiolitis feel better. But obviously we are doing things if we're giving them oxygen and we're supporting their feeding. But I would love them to invent a new medicine that would help. So if you're a pharmaceutical company out there, if you could just invent some new medicines for bronchiolitis, that would be great.
Definitely. Yeah, like just seeing little baby struggle is just not what anyone wants, is it? You feel so helpless for them because they can't communicate at all.
Yeah. And you know that there is a new RSV vaccination.
Yeah, so from 28 weeks, if expectant mums having the RSV vaccine in pregnancy, I believe you can, I looked at some research on it yesterday actually, Lily, and it said that you can reduce the RSV admissions for under 6 months old by like 81% by having the vaccine in pregnancy. Like,
we're really hoping that we're going to see that. I think because it only came out last summer, didn't it? It hasn't.
I had it when I was pregnant with Alfie, so he's 10 months. So yeah, I think it was quite new then.
Spring, summer last year, I think it started, and we haven't quite seen the reduction that we maybe were hoping for this year, but I think it maybe was just a bit too soon, and the uptake of the vaccine hasn't been like complete. I know that several of my friends, they had to ask about it. It wasn't quite completely woven in yet, but I hope that going forward it will be completely routine, and in the NHS, when you're having your antenatal checks, you will be offered this. And I think it's so important to know how important it is to have it to protect your baby, because as I said, when you get bronchiolitis, if you're a 2-3-year-old, it's going to be a lot milder illness than if your baby gets it at 3-4 months. And if you have older children, they are vectors for viruses, and so especially if this is your second, third, fourth baby, the chances of your older children catching RSV and bringing it home from playgroup, school, whatever, is really high. And then your younger baby will catch it, and they're the ones that will struggle more than your older children. So if there's anything you can do to protect them against this, I think do it, in the same way that you're offered whooping cough vaccine in pregnancy. And that's another illness that I have to admit, when I first became a paediatrician, I had never seen whooping cough, but in the last year to 2 years, I have seen many cases of whooping cough in babies, and that is because of dwindling vaccination rates, and there's just more of it out there in the community, and that's typically called the 100-day cough. So it's another virus illness that causes it causes 100 days of coughing and it will be a cough that just won't go away. So it goes on and on and on and on and on.
Definitely. And if you're listening and thinking, actually, I am pregnant and I want to explore these vaccines, do go and speak to, your practice nurse or your GP or your midwife, and get the information so that you can make informed decisions about, your options with vaccines in pregnancy, because we've got some really good safety evidence on these vaccines. So it's really worth exploring and seeing if it's something that, you want to have in your pregnancy. So thank you, Lillie. It's so helpful, because I know this is such a vast topic and we could literally talk for an entire week about it. But I think it's hopefully reassuring for parents to feel a bit empowered about what they can do to help their babies and how they can get to know their norms, so that hopefully they just get that intuition when something isn't quite right. And everyone that comes on the podcast, as you know, I always ask for 3 top tips to finish. So I wondered if you could give us your 3. It may well be a summary of some of the awesome tips you've already given, which is perfect too.
I think when it comes to breathing, you need to know your child's normal. That's my top tip number 1. So as you said, it's really difficult to see it under 4 layers of clothing. So when they are naked or in a nappy, have a really good look at how they're breathing. It's really helpful if it's when they're asleep and they're not moving around so much. Number 2 would be know the signs of when to worry. Know about recessions, about tracheal tug, about nasal flaring, about grunting. Just have those things in the back of your mind. And if you don't know what those look like, just go on YouTube and have a look. You can put in respiratory distress baby, and there are several videos of babies who are struggling to breathe, and you can have a little look at those. And I think number 3 would be trust your gut instincts as a mum. I mean, I always say this as my top tips, because I think as a mum, you know your child, you know what is normal for them, you know when they don't look well, and it's really easy for a doctor or a healthcare professional who's never met your child before to kind of see them and think, oh, they look okay. But as a mum, you know what they look like normally. And I often have parents say to me, I know they look fine now, but really, really, they didn't look well earlier, or actually, this is harder than they would normally breathe. And I know it doesn't look too bad, but definitely this is different to normal. And I don't ever ignore that as a paediatrician. I will often give it more time or observe for longer. And I never want to send anyone home until they feel happy to be sent home. So I think advocating for your child and making sure that you get your points across. If you're worried, make sure that people know that you're worried, because it's so easy for a doctor just to say it's fine, and as a parent, if you're not medical, just to say, okay, well, they've said it's fine, so it's fine.
Absolutely.
But actually, if you don't think it's fine, say, I don't think this is fine and I'm worried, and we will listen.
Oh, Lillie, thank you so much. You are such a bundle of amazing essential knowledge. So thank you. And if you have found everything that Dr. Lillie has said really helpful, then do check out the episode description, because she puts incredible, helpful and easy to understand resources on her social media account. Thank you so much.
you have listened to this birth story, enjoyed it, and feel that you are ready to really embrace and dedicate yourself to having the most informed, supported, and empowered journey, and want to see if we may be able to support you in YPJ, your pregnancy and postnatal journey, please drop me a Instagram DM at midwife_pip or get in touch on my email, pip@midwifepip.com, and let's chat through things and see if we might be a good match for each other. I hope you've enjoyed listening and wishing you all the best on your journey through pregnancy, birth, and beyond.